Hello everyone. Today the topic which we are going to discuss is measles. As we know, measles is a common exanthematous viral illness that causes around 3,50,000 deaths over in the developing countries, out of which 80,000 deaths do occur in India. From that, we can easily know how dangerous this disease is. Then coming to the pathogenesis, measles is caused by RNA virus that belongs to Paramyxoviridae family. It transmitted by droplets. The secondary attack rate, the susceptible contacts, out of these contacts, 90% develops measles. So secondary attack rate is almost 90%. Incubation period is around 8 to 12 days, that is around 10 days. Period of infectivity, day for 4 days prior to the onset of rash to 5 days after the rash, the period of infectivity is like that. So this period is very dangerous. The infection can spread within this period. Then coming to the clinical feature, the infants are protected because of the transplacental antibody they receive from their mother. Then the prodromal phase, the infection do occur with fever with CCC, that is cough, coryza and conjunctivitis. Conjunctivitis is bulbar conjunctivitis, that we have to remember. In another one condition, we can get bulbar conjunctivitis, that is in Kawasaki. So bulbar conjunctivitis we can get in two conditions. One is measles, another is Kawasaki disease, that we have to remember. Then pathognomonic sign, there the Copley spots is the pathognomonic clinical feature we can get in measles, that we can get around day 2 to day 3 of the illness, opposite the second lower molar tooth, that we must remember. Then rashes, this is a disease in measles. Rashes do appear on day 4 of illness, first as macule behind the ears, then spreads downwards over a period of 2 to 3 days. But one thing we must remember, the rashes coincident with the high grade peak of the fever. Other diseases like rogeola, where rashes appear once fever subsides, but here rashes and fever coincidentally they do present simultaneously. This we have to remember, otherwise it will be difficult for us to differentiate measles from other viral illness. Next is, what are the complications? Complications, it is because of the widespread mucosal damage and immunosuppression caused by the measles virus. The complication, otitis media, that's we have to remember, because it is the most common complication in children. In children, otitis media. Then is bacterial bronchopneumonia that we can get. Then giant cell pneumonia. Flaring up of tuberculosis can occur because of the immunosuppression. Then persistent diarrhea, appendicitis, ileocolitis, all these are the complications of measles. Then we can get noma or gangrene of the cheeks, that is also important. And last but not the least is SSPE, subacute sclerosing panencephalitis, that it is a chronic complication of measles that can occur after some years, 5 to 7 years after the measles infection, because of the persistence of the mutated measles virus inside the cerebral parenchyma, brain parenchyma, which do revive its virulence after some years, and that is a neurodegenerative disorder, and almost it will lead to death. So it is the most dangerous, though less but most dangerous complication of measles that we have to remember. Otitis media, flaring of tuberculosis, bronchopneumonia and SSP, these are the things we must remember as the complications of measles. Next is, what is the diagnosis? Diagnosis is mostly clinical. Fever with CCC, cough, coryza and conjunctivitis, with Copley spots and with rashes on day 4 of fever. These are the clue points we should remember to diagnose a case of measles. And measles diagnosis is mostly clinical, and another is lab finding. Lab finding is IgM anti-measles antibody that we can get after day 3 of rash, and that can persist up to 1 month. Next is, what are the differential diagnosis? We have already discussed. One is rogeola infectum, one is Kawasaki disease. Then others we can get rickets cell infection, meningococcemia as other differential diagnosis. Rogeola infectum is most common because fever with rash, everybody will, all parents will tell that this is because of measles. Measles segala, measles segala. It's not measles, because in rubella, once fever subsides, then only rashes appear. But in measles, on day 4 of fever, along with high grade of fever, rashes do appear. These are the things we must know to differentiate measles from Rugella infectum. Then Kawasaki disease. We know the typical pentad of criteria in Kawasaki disease. That is non-suppurative bulbar conjunctivitis, strawberry tongue, unilateral cervical lymphadenopathy, fissuring of lips, and edema of the hands, and scaling. All these things we can get with high grade of fever for 5 days. Then we can suspect Kawasaki disease in one extremely irritable baby. That can be suspected Kawasaki disease. And next, rickettsial cell infection. In rickettsial cell infection, one clue point is face is spared. Rashes appear all over the body, but face is spared in rickettsial cell infection. Then meningococcemia, we can get petechial spots, and there will be absence of any upper respiratory tract signs like cough, coryza, conjunctivitis. We won't get in meningococcal infection. These are the clue points which we should remember while diagnosing a case of measles. Rugella infectum, meningococcemia, then Kawasaki disease and rickettsial cell infection. These are things we must remember. Then treatment. As we know, treatment is just like other viral infection. It is supportive only. But nowadays it is seen vitamin A therapy. It reduces both morbidity and mortality in a case of measles. Single dose of vitamin A, 1 lakh international unit for children less than 1 year, and 2 lakhs international unit for children more than 1 year would be the gold standard of treatment, and it would prevent definitely both morbidity and mortality in case of measles. Next is prevention. As you know, prevention is always better. So for prevention, one thing left is avoidance, which we cannot do. Next is vaccination. Vaccination, MMR and MR. MR is given in our NIS, National Immunization Schedule, and MMR as per IAP. It's a live vaccine. It has to be given subcutaneously at 9 months completed age, and after second dose can be given at 15 months, and third dose can be given at 4 to 5 years. These are the things we must remember. Then there is something which led to less vaccination previously, that is infant death previously due to measles vaccination, mass infant death. That was the cause was TSS, because of the faulty mixing and the use of succinylcholine instead of distilled water as diluent. These are the things we can remember for exam purpose. Next is, these are the things what we have discussed. We must know about measles, but what are the things we are desirable to know? That is, it's better if you know. One is one giant cell that examiner would be asking in exam, Warthin-Finkel-Test giant cell. This is because of the fusion of the infected giant cell that results in multinucleated giant cells. That is the pathological finding. Warthin-Finkel giant cell. You can remember, and you are desirable to know. And then next, what you can know about measles is one question somebody may ask, what are the other places where you can get Copley spots? It can be seen other places like lips, hard palate, gingiva, even conjunctival folds and vaginal mucosa. You can get Copley spots in a case of measles. These are the things you can remember. Another is, what do we mean by modified measles? Modified measles, those persons who have received passive immunity either because of the transplacental antibody from mother, like in infants, or those who have taken a vaccine already, they may not develop the typical rash, rash and complication what we usually get in a case of measles. That is modified measles. And it is seen the modified measles, they are not highly contagious. This we can remember for MCQ purpose. Next is almost key points, desirable to know, what we should desirable to know. Already we have discussed. Another is quiz. Only 2 questions that I will be asking. One is, what is the other name of measles? Other name of measles is rubeola. That we can know. Other name of measles is rubeola. And second is, what is the strain of the measles virus that used in vaccines in India? That is, we can know for multiple purpose, for MCQ, that is Edmondson-Zagreb strain. That we are using Edmondson-Zagreb. This term rubeola. These are the two things we can remember for MCQ purpose. Thank you.